Brilliant.
Okay. So the first slide I've got is literally a picture of hands holding the world. And the next slide is really to say a very warm, broad, huge welcome to everybody. So hopefully we've made this, or we're aiming to make this event as accessible as possible. You're going to arrive as an attendee already muted with your cameras off, and you won't be able to unmute yourself or show your camera. Only the presenters can do that. And that is mainly so we can try and reduce the background noise as much as possible, because we know how difficult that can be. If you need any support, those of you who can, raise your hand in the webinar control, and Catherine will be notified you've raised your hand, and we'll message you personally to help out, to assist you. You can ask questions in the Q&A box, and we'll aim to answer those. Of course, sometimes we don't know the answers, and we have to follow up afterwards. So we can come back to you. And we've had questions sent in from delegates, so thank you very much for those. I will raise those with different presenters as we go through the day. All of the sessions are being recorded, and we do use some of the photographs afterwards for when we kind of upload the sessions. We really edit those down, and we do a top tips. But if you don't want to be recorded, or you don't want your name to appear anywhere, please just do let us know. Okay, so that's a big welcome. Thank you, Catherine. So it's for everybody in our Ulstrom community. I said at the beginning, we've got some people who perhaps aren't necessarily connected but want to know more about Ulstrom. You're very welcome too. Part of the work of this conference is that we are starting to work very collaboratively with our European partners and internationally. And it's very, it's just so brilliant to hear from families and professionals from all around the world, to learn and listen to their experiences and really learn from each other. Okay, brilliant. Thank you very much. The next slide has a kind of brief overview of the day. And the reason I'm using this one is just to give you a sense of, our route of the day, the map of the day, and just to kind of also assure you we're going to have quite a few breaks. They're probably short breaks, but nonetheless, so you get a chance for a breather and a cup of tea or coffee. So this afternoon session, we're going to talk about the liver. We're going to look at the Ulster mouse, and we're going to have updates from around the UK. Then we'll have a quick break. Then we're going to listen to Pietro from Italy talking about practical tips. Then we're going to have Dr. Shyam, who will be talking about the importance of sleep. I'm very much looking forward to that session. And then some updates from Italy. Then we're going to hear from Melissa, one of our trustees, talking about mental health and the road to independence. Then we're going to have updates from America. And again, we'll have a quick break. Then at 4:35, hopefully we're running to time. We're going to listen to Professor Tim Barrett from Birmingham, from the UK, who will be talking about children's growth, puberty and diabetes. And then one of our trustees is going to talk about education. Bernd is going to give us some updates from Germany. And again, we'll have a quick break. And then we've got some updates from China and a dad and family's experience of kind of moving from Hong Kong. Then we're going to listen to one of our younger people with Ulstrom, who's going to talk about cochlear implants. And then updates from the USA. Delighted Jamie can join us, and she's going to talk about the A team in America. And then we're going to, the final kind of towards 7 o'clock, we'll just be kind of doing a roundup, some conclusions. And then I'm very hopeful that we have a very special appearance from Lexi, many of you know, as a former trustee of ASUK, and her new arrival, Amelia. I'm hoping that she might be awake and that she can join us for a few moments. So again, a warm welcome. There's people from around 23 countries, including Romania and Sweden, Turkey and Jersey. People join us from Palestine and Croatia and Portugal and Poland. You are all super, super, super welcome. Really looking forward to listening and learning together today. Okay, so I am going to try and keep us to time. For those of you just coming in for one session, I'm very hopeful to try and keep that timing exactly right. Now, unfortunately, we have had one cancellation, and that is from Professor Tariq Hiwat, who has been, many of you will know, but fortunately, we're delighted to say that Dr. Sadaf Ali, who has been very involved in the semaglutide research, has stepped in at the last minute. Very thankful to her, and is going to cover exactly what Tariq was going to cover. So I'm going to pass you straight over and she can introduce herself. Thank you and welcome. So if we go straight over to Sadaf. Thank you, Sadaf. Thank you.
Hi, everyone. Hello. Can you hear me?
Yes.
Lovely. And can you see me as well?
Yes.
Amazing. Thank you very much, Anne, for your kind words. My name is Sadaf, and I'm Professor Hivert's Research Fellow. Professor Hivert has sent his apologies as he can't be here today. And I'd be mainly sharing my last 3 years of research experience as a part of my PhD, working and mainly exploring the metabolic aspects of the disease. So I will start with sharing my slides. So the talk mainly is about sharing the research experience in Birmingham, mainly the metabolic aspects of the disease. So I'll start with giving a little bit a history about Birmingham. So Birmingham is located in the center of the West Midlands region of the England, with a population of over 1 million, and often hailed as Venice of North. The historic canals of Birmingham gracefully wind through the city, showcasing its industrial history and standing as a captivating symbol of urban renewal. In recent years, Birmingham has undergone a remarkable transformation, evolving into a modern and vibrant urban landscape. And Birmingham thrives as a hub for technology, commerce, and culture while preserving its rich heritage. UK Alstrom Syndrome National Service Centre is based across at University Hospital, Birmingham. We have been a centre of clinical and research excellence with large number of Alstrom patients under our care. We have various national and international collaborators alongside a very strong network of Alstrom syndrome patients and their families who are committed to make a difference. We are supported by AS UK, who by their hard work are committed to provide care and support to patients with Alstrom syndrome and their families. Little bit about metabolic syndrome. So essentially, it's a term that's given when you have a combination of being overweight, obese, dyslipidemia, alongside high blood pressure and type 2 diabetes. And obesity and insulin resistance are linked to each other. And in simple words, insulin resistance is inability of your body to effectively handle insulin that's normally produced in the body, and obesity, particularly excess fat around your tummy, has been identified as a major player for the development of insulin resistance, which is your body inability to handle glucose in response to insulin release. The more fat or adipose tissue you carry, the more likely it is to release inflammatory substances and thus disrupting the normal function of insulin, leading the cells to become less responsive to insulin call, resulting in elevated blood sugar levels. And as we all know, the elevated blood sugar levels over time can lead to type 2 diabetes and its various attendant complications such as high blood pressure, dyslipidemia, non-alcoholic fatty liver disease, and high risk of cardiovascular disease. Now, a little bit about metabolic syndrome in Alstrom patients. Patients with Alstrom syndrome suffer with childhood obesity. They are insulin resistant from a very young age, and it precedes the development of type 2 diabetes by many years. There is evidence to suggest that insulin resistance may be as early as 18 months of age. Alongside, there are other complications of metabolic syndrome, which include accelerated non-alcoholic fatty liver disease that does progress to end-stage liver disease, and it is as early as second to third decade of life in Alstrom patients. In our clinics, there has been remarkable examples of both short-term control of diabetes and long-term remission of diabetes and weight loss that is maintained over time just with incorporating dietary and lifestyle changes, mainly to do with the diet and exercise. Now, the question is, why do patients with Alstrom syndrome suffer with extreme insulin resistance, which is disproportionate to their body weight or their BMI? In order to answer this question, I'd just want to introduce a concept of a metabolically healthy and metabolically unhealthy obesity. Now, on the extreme right, you can see a person. This person is healthy, is normal, um, and has got a BMI in a perfect normal range of less than 25 over 18. He's overall reduced body fat, increased muscle mass. He's quite fit. He's got normal insulin sensitivity, normal blood sugar levels, and he's got quite a low cardiovascular risk. Now, the second person following that is someone who's got an absolutely normal and healthy weight, but he's metabolically unhealthy. Now, what do I mean by this term? Now, we have seen people around us that have absolutely normal weight, but despite of that, they have type 2 diabetes or they do have high cardiovascular risk. So these are the people that fall in a category of people that have a normal BMI, but they are metabolically unhealthy. And essentially, what I mean by that is that they have excess visceral fat, which is the layer of the fat that protects your organs in your body. They are not as fit as their counterpart. People that are fit and they have normal insulin sensitivity. These people have insulin resistance, diabetes, high cardiovascular risk, and high cancer risk. Now, we move on to a category of people that are obese. Now, in our personal around us, we have seen people that are quite overweight, but they never develop either diabetes or any obesity-related complications all their life. Now, these are the people that have obesity, but they are metabolically healthy. Essentially, they have more fat under their skin than they have around their organs, which is called a visceral fat. They have increased muscle mass. They are more fit. They have normal insulin sensitivity, normal blood sugar levels, and a low cardiovascular risk. And there comes people that are obese, overweight. They have more visceral fat. They have muscle loss. They are hyperinsulinemic. They have diabetes and all the attendant complications associated with obesity, including high cardiovascular risk. Now, I want to talk a little bit about the adipose tissue, which is essentially the fat in your body. It is a specialized form of a connective tissue that plays a critical role in the energy balance in your body, and alongside it provides insulation and protection to your viscera or to your critical organs that are required for your body to function normally. Um, this connective tissue consists of mainly lipid-rich or fat-rich cells, which are called adipocytes. They make up about 20 to 25% of a healthy person's body weight. Depending on where this fat is located, it can be either under the skin called subcutaneous fat or surrounding the organs called visceral fat. Based on how they look, it can be either white, brown, beige, or pink adipose tissue. Now, the next figure just gives you a little bit idea about the variety of the fat cells that we have. A white adipocyte, as is clear by its name, has one large lipid or a fat droplet, and all the other organelles are pushed to one side, giving it a white hue. The brown adipocyte has got iron-rich mitochondria alongside small droplets of lipids, and hence it's called a brown adipocyte. Then we have something called a beige adipocyte that has features of both white and brown adipocyte, and then a pink adipocyte that is found in lactating low organisms, and it's still a matter of debate whether this kind of adipocyte is present in humans. I'll talk about what do these fat cells do in our body. So essentially, these fat cells are the storehouse of lipid or fats in our body, and they regulate a balance between the breakdown of fat and synthesis of new fat. And the fat that's stored in them can be mobilized and utilized when body needs additional fuel. Additionally, these cells are extremely insulin sensitive, and they take up the glucose in response to insulin and then convert it into fat or triglycerides, which are stored inside these cells. Alongside, these cells have important secretory functions. They make up variety of hormones, variety of signaling molecules, and in scientific terms, these are called adipokines. These can increase insulin sensitivity, and there are various other inflammatory cytokines that are produced by these cells that, if produced in excess, can contribute to insulin resistance. Now, you can imagine that if the function of these cells is disrupted, and any of these function is disrupted, it can contribute to various obesity-related complications. Now, I'll talk a little bit about the study, which my colleague did a couple of years ago. Essentially, we had patients with Alström syndrome. We had 12 patients with Alström syndrome. Alongside, we had normal control volunteers that were weight or BMI matched to these Alström patients for the study. And by the side, we had a group of patients with extreme form of obesity, and they suffer with a syndromic obesity, and it's a syndrome called BBS or Bardet-Biedl syndrome. Now, at the bottom, there are some of the baseline characteristics of these patients from our study. As you can see that the weight in patients with Alström syndrome, the average age in 12 patients with Alström syndrome was about 76 kilos. The weight in obese controls was way more higher than patients with Alström syndrome, being 93 kilo, and significantly more higher in patients with BBS, over about 120 kilos. Now, when we look at the percentage of diabetes, it was way more higher in patients with Alström syndrome, being 67%, versus no diabetes in our control volunteers, and only a 13% patients with diabetes in BBS group. When you look at the Alström patients in the group that suffered with non-alcoholic fatty liver disease, it was way higher in Alström patients as compared to the obese controls or the patients with BBS. And over half of these patients with non-alcoholic fatty liver disease had some form of liver scarring or fibrosis. On the other hand, none of the patients that were in the control group or the BBS patient have had any scarring or cirrhosis of the liver. Alongside, we did subcutaneous adipose tissue biopsy in all these three groups. And on the right-hand side, you can see this is the histology of the fat cells of patients with Alström syndrome. In the middle, we have matched control volunteers. And on the extreme left, we have patients with BBS. Now, you can clearly see that the fat cells in Alström patients are larger in size, and there was adipocyte heterogeneity in patients with Alström syndrome in comparison to the matched control or BBS patients. Now, we also did something which is called a hyperinsulinemic euglycemic clamp, and we looked at the responsiveness of the subcutaneous adipose tissue, lipolysis, to insulin infusion, which was quantified by the interstitial fluid measurement of the glycerol levels. And this was mainly to see whether infusion of insulin reduces or has any effect on the levels of glycerol, and whether lipolysis was suppressed once the insulin infusion was given in these people. As you can see, at the baseline levels, the rate of increase of the glycerol, which is showing us the lipolysis, is more or less the same in patients with Alstrom, obese control, and BBS. But at 120 minute, when these patients had insulin infusion given, you can clearly see that in control subjects, which is shown by a green, and the BBS patients are shown by a blue color. In control patients, you can see that the rate of the interstitial glycerol release was suppressed, but insulin failed to suppress the lipolysis or glycerol production in patients with Alstrom syndrome. Now, we also measured the lactate and pyruvate levels in the interstitial fluid, and we did a lactate pyruvate ratio. Now, essentially, this is a marker of mitochondrial dysfunction and oxidative stress. And the lactate pyruvate ratio was significantly higher in patients with Alstrom syndrome, thus showing that there is mitochondrial stress within adipocytes in these patients with Alstrom syndrome in comparison to the control obese or BBS patients. So when we take all these findings together, including the histology of the adipocytes and some of the functional analysis of these adipocytes, there is a very strong evidence that adipose tissue may be dysfunctional in these patients with Alstrom syndrome, what we called a relative adipose tissue failure. Alongside, we also did the gene expression for GLUT4 expression on adipocytes in these patients. And what we found was that the expression was nearly half in comparison to control. GLUT4 essentially, in response to the insulin, helps with the transport of the glucose inside the cells. And this clearly shows that there was a decreased expression of GLUT4 receptor, thus affecting the transport of glucose across the cells and resulting in impaired insulin sensitivity within adipocytes in these patients. So to summarize what I've said so far, patients with Alstrom syndrome have insulin resistance, which is disproportionate to their weight. Insulin resistance is mainly driven by relative adipose tissue failure or adipocyte dysfunction. And it is the quality, not the quantity of the fat that matters. An ARMS1 mutation is associated with decreased expression of GLUT4 and adipocytes, thus causing overall extreme body resistance that is seen in these patients with Alstrom syndrome. Now, the question is, what can be done about it? Is there any way to ameliorate the extreme insulin resistance or metabolic syndrome in these patients with Alstrom syndrome? And we at Birmingham have shown that GLP-1 analogs are extremely effective and safe for weight loss as well as glycemic control in these patients with Alstrom syndrome. But before I share the results of the study, I want to give you a little bit idea about these agents, that what these agents are and what they normally do in our bodies. So essentially, GLP-1, also known as glucagon-like peptide 1, and GIP-1, also known as glucose-dependent insulin-trophic peptide, they both are normally produced by small intestine. They're also known as incretin hormones, and they're mainly released in response to food intake. They both help to release insulin from pancreas in response to the glucose, and therefore it increases the peripheral glucose uptake and overall reduces your blood sugar levels. In addition, GLP-1 also helps to reduce the stomach emptying, and therefore food stays in the stomach for longer and you feel fuller after having a small meal. There is also some evidence to suggest that GLP-1 analogs may have receptors in hypothalamus and brainstem, and that helps for the physiological control of the appetite and food intake. Now, there's been clinical trials of efficacy of these medication, particularly once weekly semaglutide in adults with overweight and obesity. And the results have been remarkable. There have been weight loss in patients that were given semaglutide. Slightly higher dose at about 2.4 milligram once weekly as compared to the doses that are normally given for weight loss or glycemic control. And this was in addition to diet and exercise or lifestyle modification. And as you can see in the placebo group that was only given diet and lifestyle, there's significant more weight loss in semaglutide group that is shown in blue, and the placebo that is shown in gray. And on the right-hand side, you can see that in semaglutide group, the people that lost clinically meaningful weight was significantly more higher in comparison to placebo, which was only 30% of the participants. Now, I'll talk a little bit about what we did at Birmingham. So essentially, now there was an evidence of efficacy of these medications in obesity, although there wasn't much evidence around use of these medications in genetic obesity. But we trialed these medications on the basis of how they work. And we screened 72 patients that were under our care to see whether they were suitable to start on GLP-1 analogs. We excluded 38 patients, and the patients that were excluded were mainly the ones that had end-stage heart, liver, kidney disease, or they had end-stage malignancy. We offered treatment to 34 patients. 4 patients withdrew, mainly because of mild to moderate GI-related side effects of the medications, and 30 patients completed 6 months of treatment with GLP-1 analogs. And I'm quite glad to say that none of them have had any serious side effects. They were only mainly transient mild to moderate GI side effects. A little bit about the baseline characteristic of these patients that were given GLP-1 treatment. The average age was 31. Majority of them were male. With regards to the GLP-1 analog we used, about a quarter of the patient were on exenatide twice a day injections. Then about 70% of the patients were on semaglutide. It was either in the form of injectable once weekly or oral tablets. Again, that was purely personal preference. Then as you can see, insulin levels significantly higher, extreme form of insulin resistance, insulin sensitivity index was quite low at 0.2. Majority of them have had type 2 diabetes and hypertension. All of them have had non-alcoholic fatty liver disease. All of them were on metformin, and some of them were on other anti-hyperglycemic medication, including SGLT2, insulin sulfonylureas, and pioglitazones. The parameters that we looked at were their weight, blood pressure, HbA1c, lipid profile, their LFTs, and their kidney functions. And I'm quite glad to report that there was 6% weight change from baseline at 6 months in these patients. There was some improvement with their systolic blood pressure, alongside a 1.1% reduction of their HbA1c at 6 months. There was improvement across the lipid profile. There was across all the different parameters of the lipid profile, including your triglyceride, total cholesterol, your HDL-C, and they did show slight increase in their HDL levels. There was reduction in their ALT levels, and there was some reduction in their AST levels as well. As you can see, that wasn't statistically significant. And that could be because of the number of the participants that had this specific test done, which is only a small percentage that routinely has AST levels checked, as this was done a part of a routine medical care rather than a well-designed research study. Now, of all the patients that showed weight loss, there was 62% of the patients that have shown clinically meaningful weight loss, which was at least a 5% over 5% of the weight loss. Now what's next? Tirzepatide is a combination of GLP-1 and GIP-1, and in trials, it's shown to be more effective for weight loss in comparison to 1 milligram, which is the standard doses of semaglutide once weekly. As you can see, the top dotted lines is your change of weight from baseline, which was about 6 kilo weight loss. And you can clearly see that the weight loss observed with the smallest dose of tirzepatide as 5 milligram once weekly is superior than the weight loss alone with the GLP-1 analog only. And the weight loss effects with tirzepatide are dose dependent. As you can see, the weight loss with highest dose of tirzepatide as 15 milligram is double than the weight loss that was associated with a standard dose of semaglutide at 1 milligram once weekly. Similar effects on the overall blood sugar control. The effects are much more pronounced in the smallest dose of tirzepatide in comparison to a milligram once weekly dose. And again, that's dose dependent. If you go on a higher dose, the effects are much more pronounced for your blood sugar control in comparison to a standard dose of semaglutide at 1 milligram once weekly. So to summarize, patients with Alström syndrome have poor quality fat cells. Weight loss in these patients is quite difficult, but even a small weight loss can make a big difference. Good metabolic control can increase the survival by at least 20 years for most patients with Alström syndrome. And long-acting GLP-1 receptor agonists are effective and safe in patients with Alström syndrome. I'd like to end my talk by expressing my sincere gratitude to patients and their families for their pivotal role, the timeless efforts of ASUK, clinical and research teams, and our invaluable national and international collaborators, without whom the work we have carried out would not have been possible. Thank you.
Okay, thank you very much, Sadaf. I've got a couple of questions for Sadaf that have come in. If the one, first of all, Sadaf, can you still hear me?
Yes, I can.
Okay, perfect. So the one question that has come in is you said there were some side effects, although you said there are mild side effects. I wonder if you could just briefly describe what they were.
Yeah, of course. So the side effect that Alström patient has had with GLP-1 treatment are more or less similar to what is being reported in the clinical trials and real-world experience of use of these medications in patients with type 2 diabetes, and when these medications have been used for weight loss in tier 3 and tier 4 services, which is mainly your GI side effects. That's mainly nausea, abdominal cramps, and diarrhea. Well, I wouldn't want to call it diarrhea, mainly loose stools, I'd say. And they all are transient side effects, and they do tend to resolve over time. So it's just for your body to just get used to the new medication, and when you start these medication, you use an approach of gradual up titration of a dose to then eventually be on a dose that is clinically effective. So it's when you go on, like, start at a small dose, and a week later when you increase the dose again, you have transient side effects, but then they tend to resolve. But in literature, there have been report of some serious side effects like pancreatitis, which is like inflammation of your pancreas, but none of our patients had reported any of the serious side effects or anything more than a mild to moderate GI side effects.
Okay, perfect. Thank you. Again, just to repeat to the whole audience, we have recorded this and we will be posting it online for people to be able to listen, look again. So just another question for you. Obviously, some of the folk online today have been part of the trial work, And so this is a fairly specific question from one of my colleagues, which says, my pharmacy gave me 0.5 meg semaglutide made by Ozempic, sorry, and told me to double up the injection, making 1 meg. Before taking, I checked with QE Birmingham, was told not to do this. So what was the issue? Should I raise the issue further with my pharmacy? We do know there's been some issues around getting the actual meds themselves.
Yeah, so I think the issue here is that these medications have been trialed as 0.25, 0.5, and 1 milligram, or like 1.7 and 2.4. But it's not recommended that you do it because I'm not sure whether it's to do with the pharmacology, the way they work, but it's not recommended that you double up to make up the dose
Okay.
per se. So you're only supposed to have it as like a single strength as opposed to, but I think this does require to be raised because clearly the pharmacist that's giving the advice does not know themselves. But there's a very clear indication about it on the product literature that is not to be kind of paired to make up the big dose.
Okay.
Yeah.
Okay, I think we follow that up individually if you're happy
Yeah.
to do that. So just one further question, Sadaf, before we say goodbye to you. One question from one of our folk which says, how much weight would you lose with the semaglutide? And would you give those medications to us when we come to the clinic?
Yeah. So essentially, there are, when I said we kind of screened all the patients and we excluded a few, so there are a few things that we do need to kind of a checklist to go through, whether you do will benefit with this medication. However, NHS guidelines are very stringent with regards to the BMI and the sugar control to start these medication. But with my experience of using these medication, even if you have a BMI that is not hitting at 25 or 24, which is way more less than what NHS or NICE recommends for these medication to be started, it still has caused excellent glycemic control in these patients that weren't overweight, but struggled with their glycemic control all their life. So what I'm basically trying to say is it's very kind of individual specific patient-centered approach that we have adopted when we have started these medication from patients. So the patient that's asked for, I'm not sure if they're under our care in UK or they are elsewhere, but that's mainly kind of a very person-specific approach,
Okay.
going over their history, glycemic control, but it can vary from one person to another.
Okay.
Yeah.
Perfect. Thank you. We will to both of those questions because there's very specific questions from individuals and they both happen to be in the UK. We can do some follow-up afterwards. We do have Chase Palmer in the US who is a pharmacologist and I know perhaps we can just bring that together somehow. But I'm going to park all of that now, just mainly to keep us on time. But thank you very much for that, Sadaf. And a big thank you for stepping in right at the last minute. It is appreciated.